today's session. So once they will join, then we'll start. Dr. Noel, are you online?
Hello, good evening, sir. Hello, hello.
Yeah, good evening. Good evening.
Good evening, sir. Sorry.
Dr. Noel has joined. So, Dr. Ramkrishna, can we start the recording?
यस सर शुरू कर रहे हैं 1 मिनट सर
या और यूट्यूब भी भेज दो लिंक.
यूट्यूब लिंक आपको भेज दिया
ओके ओके.
यस सर रिकॉर्डिंग स्टार्ट किया आपको होस्ट कर रहा हूँ
Yeah. So, welcome everyone. Today's session is on remaining movement disorder, tremors, myoclonus, and tics. And I welcome Dr. Noel Combs for moderating this session. Other moderator, Dr. Baishak, may have some technical things, issues, so he may join in between. So today's presentation is by Dr. Nidhi on tremors and remaining myoclonus and tics by Dr. Dhanya. So Dr. Noel Gomes, so you can introduce yourself, then we can start the session.
Yes,
Followed
sir.
by
Good
Dr.
evening.
Dhanya and Nidhi. Okay, sir.
Yeah,
Go ahead.
I'm Dr. Noel Gomes. I'm Assistant Professor of Neurology in TN Medical College and Nair Hospital, Bombay. So all the best to the presenters and other exam going students.
Yeah, Dr. Nidhi and Dhanya, you can introduce yourself, then we can start.
Good evening, sir. I am Dr. Nidhi. I am DM resident at Medical College, Jodhpur. Today I am going to present the tremor and its
Okay,
related
1
part.
minute. Dr. Dhanya, you can introduce yourself.
Yes. Good evening. I'm Dr. Danya. I'm doing my third year residency in Apollo Hospitals, Chennai. Today I'll be presenting myoclonus and tics.
Okay, Dr. Nidhi, you can go ahead.
Yeah. So today we will be discussing about the tremor. So in layman language, we can say tremor is a rhythmic shaking of a body part. The definition is it is defined as involuntary rhythmic oscillatory movement of a body part which is produced by alternating or synchronous contraction of agonist and antagonist muscles. Next. So the phenomenology is the tremor can be classified clinically as rest tremors or action tremors. The rest tremors occur in a body part that is not voluntarily activated and is completely supported against gravity. And the action tremor is any tremor which is produced by the voluntary contraction of a muscle, and it includes the various parts like postural tremors, kinetic tremors, intentional tremors, task specific, and isometric tremors. Next. Postural tremor is present when patient maintains a position against the gravity. Then kinetic tremors occurs during a voluntary movements. Like in kinetic tremors, we can divide it to three parts. First is initial movement. So initiation tremors. Then during the movement, dynamic tremors, and then at the end of the movement, that is when we reach the target, it is called as intentional tremor. So intentional tremor is present when tremor increases in crescendo manner when the body part approaches a target. Then next is task specific tremors, which appears or becomes exacerbated during specific activities like voice tremors during singing and writing tremors during writing. Next is isometric tremors, which occurs during a muscle contraction against a rigid stationary object like seen in legs, called as orthostatic tremors. Next. Now the classification is we can divide it into axis 1 and axis 2. Axis 1 is clinical features and axis 2 is etiology. So in axis 1 we divide it into historical features like age at onset, then temporal onset and its evolution, then past medical history of patient, family history, and drug and alcohol abuse. And then tremor characteristics like body distribution of tremors, activation conditions, and then a tremor frequency. Then the third is associated signs like signs of systemic illness, neurological sign, or soft signs seen in essential tremor plus syndrome. And the fourth is additional laboratory test, which is electrophysiological test, structural imaging, receptor imaging, or any serum or tissue biomarkers. The second is etiology. So etiology is acquired diseases, genetic defined diseases, and third is idiopathic, which can be familial or sporadic. Next. Then activation of tremor. So the based on activation of tremor, we can divide it into rest and action tremors. In action tremors, we have kinetic, postural, and isometric tremors. In kinetic tremors, we have simple kinetic tremors which occurs at the initiation, then intention tremors which occur at the end of the movement, task specific kinetic tremors which occurs in specific task. Then postural tremor, position, it can be position independent or position dependent postural tremors. Then isometric tremors which occurs at against a rigid stationary object. Next. Now tremor syndrome, so we can divide it into various like action or rest tremors, then focal tremors, then task specific tremors, then orthostatic tremors, tremors with additional signs, or others. So in action or rest tremors, we can divide it into essential tremors and essential tremors plus, then isolated segmental action tremors, then isolated rest tremors, and enhanced physiological tremors. The in focal tremors, we can divide it into our based on our body parts like voice tremors, head tremors, jaw chin tremors, and face tremors. And essential palatal tremors, also called as myoclonus. Then task and position specific tremors like during writing or sports, especially seen in golf sportsmen and musician. Then coming to orthostatic tremors, which can be primary orthostatic and pseudo orthostatic. Then tremors with additional signs like dystonic tremors, which can be associated with dystonia. Then Parkinsonism associated tremors. Then intentional tremors and Holmes tremors, which are also called as rubral tremors. Then myarrhythmias, and then symptomatic tremors. Others can be functional tremors, which can be we have to rule out from the organic etiology, and indeterminate tremors. Next. So based on the frequency of the tremor, we can divide it into three: slow tremors, which is less than 4 hertz, then medium tremors 4 to 7 hertz, and then more than 7 hertz is fast tremors. Now examples of these, next slide. No, there is one slide in between the two. One more slide. I think that was missing. Oh, just a second. Just a second. I just. So, based on the frequency of some tremors, so primary orthostatic tremors are having the highest frequency, that is 14 to 18. So, one more next. No. I think that was missing. So based on the frequency, 14 to 18 hertz is the frequency of primary orthostatic tremors, which is highest, and it is classified as fast tremors. Then 7 to 12 also classified as fast tremors, physiological and enhanced physiological tremors. Then essential tremors are 6 to 10 hertz. Then psychogenic tremors are variable. Dystonic tremors are 3 to 10 hertz, and task and position specific tremors are also 3 to 10 hertz. Parkinson tremors are also 4 to 10 hertz, and then neuropathic tremors are around 2 to 10 hertz, and multiple sclerosis tremor is also around 2 to 10 hertz, and Holmes tremor or rural tremor are 2 to 4 hertz. So Holmes tremor are very slow, and Parkinson disease are slow, that is 6 to 10 4 to 6 hertz. Essential tremors are 6 to 10 hertz, moderate, and then physiological and enhanced physiological tremors are all fall into category of fast tremors, that in 7 to 12 hertz, and then orthostatic tremors are very fast, 14 to 18 hertz, and then psychogenic tremors can be variable. Next slide.
Yeah, I welcome Dr. Baishak. He is also a moderator along with Dr. Noy. Okay, you can continue.
Yes. Now,
So actually
pathophysiology.
the amplitude, it is kind of inversely proportional to the frequency. So the lower the frequency of the tremor, the amplitude is large. So the cerebellar or the Holmes tremor are quite large
Yes, sir.
amplitude post tremors, which
Yes, sir.
can affect the proximal muscles also. Like you see in, we can see in Wilson's disease also such kind of tremors like wing beating tremors.
Yes, sir. Then coming to pathophysiology, next slide. So we can divide into mechanical oscillations, which are due to natural limb mechanism seen in physiological tremors. Second is reflex oscillation, which is due to afferent muscle spindle pathways, which is seen in hyperthyroidism and toxic state. The third is central oscillators, like thalamus, basal ganglia, inferior olives. They fire rhythmically, and the examples are Parkinsonism tremors, essential tremors like thalamus and inferior olive, and fourth is cerebellar dysfunction. Abnormal cerebellar activity contributes to tremor. PET activity shows cerebellar activation in various tremors. So cerebellar dysfunction is the one part of the pathophysiology. Next. Now the neuronal pathways associated with tremor. So there are two important pathways. First is corticostriato-thalamocortical pathway, which involves the basal ganglia, which maintains the ongoing pattern of the movement, and the second is Guillain-Barré triangle, which consists of red nucleus, from red nucleus to inferior olive, and then the third part is made up of dentate nucleus. So this pathway is involved in the fine tuning of the voluntary precision, and the dysfunction of this pathway can lead to tremors. Next. Now coming to physiological tremors. So physiological tremors are of very low amplitude and fine tremors, 6 to 12 hertz, that are barely visible with the eye, and it is present in every normal patient while maintaining a posture or movement, but it got enhanced during certain situations like anxiety or exposure to tea or caffeine or bronchodilator use, and neurological examination is normal. So in this video uh, we can see that the patient is having physiological tremors which are very fine and having low amplitude, and it can be seen better with the placing a by putting a paper on the both the hands, and by looking at the movement of the paper. Next. Second is enhanced physiological tremors. So they are high frequency, low amplitude tremors visible while maintaining a specific posture, and they are the causes are due to drugs or toxins like lithium valproate, benzodiazepine withdrawal, or calcium channel blockers like sineregine, or medical condition like hyperthyroidism, hypoglycemia, anxiety, liver diseases. And the mechanism is due to most probably due to mechanical activation at the muscular level, and it may be influenced by heightened adrenergic activity. So these are enhanced physiological tremors. Next. So they are fine tremors. They are predominantly seen in outstretched hands, and there is no significant neurological deficit associated. So the management is removal of causative agent, and we can also give beta blockers for the symptomatic relief. Next. Now coming to essential tremors, which is the most common form of tremor syndrome. So they are characterized by both postural and action tremors, 4 to 10 or 4 to 8 hertz, and are bilateral but can be asymmetric in some cases, and they occur without a neurological sign like dystonia or Parkinsonism. These tremors worsens with activity, stress, caffeine, or improves with alcohol and relaxation procedures. And they commonly affect the hands, head, and voice, but can sometimes involve leg and trunk also. Familial essential tremor syndrome is autosomal dominant with incomplete penetrance, having 50 to 70% patient have family history. Uh, Possible some patients can have cognitive and psychiatric manifestations including dementia and social phobia due to these tremors. Like in this video we can see that the patient is having bilateral hand tremors, slightly right more than left. Now coming to essential tremor plus syndrome. Essential tremor plus syndrome is having additional neurological symptoms of uncertain significance, also called as soft neurological signs. So these patients have resting tremors, which may develop in long-lasting essential tremor cases due to overflow muscle activation. Amplitude is usually lower than action tremors, and onset is late in disease course. And they must not include cardinal signs of Parkinsonism, and we exclude well-defined syndromes like dystonic tremors or task-specific tremors, or we exclude isolated voice head tremors or orthostatic tremors and sudden onset or stepwise decline. But these how to differentiate between essential tremor and essential tremor plus is that these patients have some neurological signs, like they can have mild dystonia, or they can have mild cognitive impairment, or like they can have mild rigidity, but they do not fit into the criteria of Parkinson disease, or like they have mild ataxia but they do not fall into cerebellar syndromes. So this is essential tremor plus syndrome. Next. Now coming to primary writing tremor. So it is a rare condition which is characterized by 4 to 7 hertz tremors in the hand, and which occurs while assuming a writing posture or during writing. And it is more commonly seen in male, and it is in one third of the cases patient have positive family history, and they are also having association with improvement with ingestion, alcohol ingestion. Then electrophysiological findings, we can find isolated extensor tremors sometimes, or alternating tremors in flexor or extensor, or co-contraction of flexor and extensor here. Now the differential diagnosis of this primary writing tremor is, one is essential tremor, which is very difficult to distinguish from primary writing tremors. Second is task specific or writing dystonia. Like in dystonia, this primary writing tremors is not associated with overflow movement as well as mirror movements. So we can differentiate between the writing dystonia and writing tremors by the two findings, like overflow and mirror movements, which are usually seen in dystonia patient. And electrophysiology suggests that primary writing tremors is distinct from both essential tremors and dystonia. Coming to pathophysiology, so accelerometry suggests this primary writing tremor represents normal rhythmic movements of writing with enhanced amplitude. The treatment options are medications like beta blockers, propranolol, primidone, and anticholinergic medication can be tried. And whenever patient does not respond to medication, we can go for botulinum toxin injection in primary writing tremors. And whenever we do not have improvement with this, we can go for DBS, thalamic deep brain stimulation in some cases. Next. Now coming to Parkinson disease tremors, so they are very low frequency rest tremors, 4 to 7 hertz, and often described as pin rolling tremors, and they are also present Patient can have postural as well as action tremors also. So the key features are they are associated with bradykinesia, micrography, and muscular rigidity, and the symptoms are asymmetrical, especially in early disease, as we all know. And patient can have re-emergent tremors, that is, they appear after a brief delay, that is 7 to 10 seconds, while maintaining a posture. And patient can have tremors of the hands, leg, chin, and jaw. Chin and jaw tremors are also seen in Parkinsonism patients very commonly in advanced cases. Next. So like in this video, we can see that the tremor are having a pin rolling movement. Like the person is rolling a pill between the thumb and index finger. Like here we can also see that the patient is having bilateral tremors, right more than left, pin rolling tremors which are present at rest. Next. Now coming to differential diagnosis. So the first differential diagnosis is polymyoclonus, that is small amplitude irregular movement which is seen in multiple system atrophy but not in patient of Parkinson disease. And second is internal tremors, which is subjective feeling of tremors which is often seen in chest, abdomen, and extremities, not visible externally and often not responsive to anti-Parkinson drugs, and it may be associated with anxiety. So here we can see the patient is having very fine movements of the at the distal end of the hands. Like it is like movement, some uh, bilateral movements at hands. Then characteristic of Parkinsonism versus essential tremors. So in essential tremors, we have postural and action tremors, while in Parkinsonism, we commonly have resting tremors. Essential tremors affect all the age group, while Parkinson tremors are mostly seen in older age, that is more than 60 years. Family history is positive in essential tremors, which is not so positive in Parkinson tremors.
Wi-
Alcohol responsiveness is seen in essential tremors, but it is not seen in Parkinson tremors. And the
Will you
tremor,
see rest tremor in essential tremor?
sorry, sir.
Will you see rest tremors in essential tremors?
Yes, sir. In advanced stage, we can have resting tremors in essential tremors also. In advanced
Okay.
disease, sir, only.
So
Yes.
how will you differentiate and why it happens?
We can differentiate, like, sir, at the onset, the essential tremor patient will have bilateral onset, while Parkinson
No.
disease is
Upon
usually.
examination, somebody has a rest tremor and
Yes, sir.
sitting in front of you. We are discussing like practically when the patient sitting in front of you. How
Yes,
will you
sir.
differentiate that?
Like pin rolling movement is like typical of these
Pill rolling
Parkinson
mode is
tremor.
not there. Pill rolling mode is not always present in all Parkinson's. It may not be there. You see just rest tremor. Patient is sitting, is having rest tremor. Plus actions. How will you differentiate whether it is essential or Parkinson and related tremors? And why this rest tremor happens in late stage? It is because the rest posture also is a posture. So when it is very severe, the rest position also they will have tremors. So how to differentiate is you tell the patient to do a finger nose or some movement. If it is or
Okay.
you tell them to extend the hand. Upon movement, usually the Parkinson and tremor decreases. But the
Yes, sir.
ET component upon movement it increases.
Yes, sir.
So if you have a rest tremor and which increases on movement or on posture it increases, that favors more of ET or cerebellar outflow
Okay.
tremors. But if it is on movement, it resolves completely or reduce too much, then it is more of a dopamine insufficiency or dopamine blockade.
Yes. Yes.
Okay, continue.
Mm. Then muscle tone is, we can see cogwheel rigidity in Parkinson tremor. Facial expression are decreased in Parkinson tremors while it is normal in essential tremors. Gait will be decreased, arm swing seen in, and we have fascination and shuffling gait in Parkinsonism disease. And tremors latency during hand suspension is very short or none in essential tremors, but it is longer, like 8 to 9 seconds also called as re-emergent tremors in Parkinson disease. Next. Now coming to cerebellar tremors, so also they are also slow frequency 3 to 5 hertz tremors which occurs during goal directed movements, and amplitude increases with movements and as the target is approached, so also called as intentional tremors. Postural components may also be seen in these patients. Signs of cerebellar dysfunction like ataxia, dysmetria, dysdiadochokinesia, scanning speech, dysarthria can be present along with the tremors. Next, like here we can see when we ask the patient to do finger nose test, like he is having much higher tremors while reaching at the nose. Mm. Now, next is titubation. Titubation is rhythmic, slow frequency bobbing movement of the head or trunk. It is commonly seen in conditions like multiple sclerosis or hereditary ataxic syndromes or brainstem stroke or traumatic brain injury. So the patient may have additional non-cerebellar findings due to involvement of the nearby brainstem structures can be present, and they are very high, very disabling and difficult to treat because they have very high amplitude. Then DBS may be a treatment option in these patients, but have inconsistent success as compared to Parkinson tremors. Next. Like here we can see this patient have yes tremors.
So what are conditions you will see head tremors?
So head tremors we can see in these along with cerebellar tremors like multiple sclerosis.
No, you don't tell about it.
Then we can okay, sir.
About the localization. Right?
Like we can have in dystonic tremors. Dystonic tremors can involve
Okay.
the head.
Basically, deturbation is nothing but a head tremor. Head tremor can occur in cerebellum, it can occur in ET and dystonic tremor. These are three conditions where you get head tremors and isolated head tremor. That is fourth thing.
Okay, sir.
So how will you differentiate ET versus in cerebellum, and how will you differentiate dystonic versus others?
Sir, dystonic tremors will usually have a null point. Second, they have dystonic posture.
Correct. Correct.
Third, they can have overflow part, so they can involve other areas also, and
Okay.
like
And
uh,
correctly, like they will have null point, and it increases on one direction, decrease on another direction, and it is more of jerky rhythmicity rather
yes,
than the classical tremors. So that is a differentiating point. May or may not be associated other areas because it may be pure cervical dystonia,
yes,
and they may have sensory trick.
sensory, yes, sir, sensory just
And what about
antagonist.
the cerebellum and ET?
Sir, in cerebellar, they will have associated features with
No,
it.
no, not
They
associated.
will
Just
have
saying that. I'm just asking about the tremor, nothing else.
okay, like sir, cerebellar
Yes,
tremors
yes, and
will
no,
be
no.
having low amplitude, high amplitude, and low frequency, while essential tremors
Yes, yes, yes,
will
and no,
have
no. How to in no tremors are seen in?
no tremor in dystonia.
Non-autonomous can occur in ET, where SS is more common with cerebellum, is what I remember.
Yes, is common with
Yeah.
cerebellum.
So these are the things practically you can see because you're going to write the practical exam. So you should know how to differentiate practically.
Yes, sir.
Yeah.
Yes.
Continue.
Next slide. Now coming to rubral or Holmes tremor, so these are they involve a combination of rest, postural, and action tremors due to midbrain lesions near the red nucleus. So the tremor characteristics are they are irregular in nature, having very low frequency 2 to 4 hertz and very high amplitude, and they are associated with associated with neurological signs like ataxia due to cerebellum involvement or other brainstem involvement, and they can be associated with hemiparesis or other weakness. Then the common causes are severe traumatic brain injury and multiple sclerosis. Like here we can see irregular, very high amplitude tremors, which are also present at proximal joints. So these are the rubral tremors or Holmes tremors. Like patient is not able to write due to these tremors. So it was post-operative, pre-operative, and this is post-operative. So patient have marked improvement after DBS. Like he can make the Archimedes spiral also. So tremor onset may be delayed, that is 2 weeks to 2 years after the lesion develops, and as we have discussed, it can be associated with hemiparesis, ataxia, hypoanesthesia, or dystonia.
Other
Or
associated symptoms will depend upon the etiology and localization
yes,
of
sir.
the lesion.
Stroke like stroke hai, MS, or we
It is
can
not a
have traumatic.
no, basically it's not a basic feature of rubral tremor.
No,
It is
sir.
a feature,
No,
it
sir.
depends
It is
upon the
association.
etiology. Yeah, it
Yes,
is
sir.
depend on
It is
etiology.
yes, sir. Yes, sir.
Yeah.
And they are very disabling and resistant to treatment. And the treatment option involves levodopa, propranolol, anticholinergics, or DBS. But the DBS is less effective than Parkinson disease and essential tremors. Now coming to dystonic tremors, they occurs in body regions affected by dystonia. So they can be postural as well as action tremors. They are having irregular amplitude and frequency. They can be no or yes tremor seen in spasmodic torticollis, and they can be irregular or arrhythmic in contrast to rhythmic head tremors, which is seen in essential tremors. And they may improve with sensory trick, that is just antagonist applied to abnormal neck posture. A null point may exist where a specific neck position reduces or eliminates the tremors, and it may overlap with essential tremors in clinical presentation and treatment option. Treatment. So the treatment option in dystonic tremors are anticholinergics, and the medication used for essential tremors, that is propranolol and primidone, and botulinum toxin is the mainstay of treatment for focal dystonia. And if the patient is not responding to above 2, we can go for deep brain stimulation, which is effective in treatment refractory focal dystonia. Like here we can see the patient is having both yes and no head tremor, along with the slight torticollis on the right side, then anticollis movement are also present along with the retrocollis. Back. Next. Coming to neuropathic tremors, so they are mostly postural or action tremors occurring in the setting of peripheral neuropathy, and they are seen in demyelinating neuropathy like dysgamma globinemic neuropathy, or recovery phase of demyelinating neuropathy like GBS syndrome. And they are 3 to 6 hertz tremor. They have 3 to 6 hertz tremor frequency in hands and arms, but it can vary significantly. The exact etiology remains unknown, and they are often refractory to treatment, but usually very mild in severity. Next slide. Like here we can see the patient is having tremors of bilateral hands, very fine tremors, only present in at wrist joint. Next. Now coming to chin tremors, also called as hereditary geniospasm. So these movements are characterized by involuntary vertical movement of the chin, which are often accompanied by quivering and mouth movements, and they can occur spontaneously or they can be induced by stress, but usually seen in infancy or early life, that is in first year of life, and the episode usually last for only a few minutes. The progression, they are less frequent to they become less frequent with age, but sometimes usually persist throughout the life. So they are genetically heterogeneous condition which are linked to some chromosomal condition, and they are a part of hereditary essential myoclonus. Next. Like in this video we can see that this child is having, no, back please, play the video. Like few vertical chin movements are there in between, like only at the tip of the chin. Next. Now coming to palatal tremor, so they are brief, rhythmic, involuntary, low frequency movements of the soft palate. So they are of two types: symptomatic palatal tremors and
One
essential
second.
palatal
A chin
tremor.
tremors, if you see in adult, what do you think of?
Ji sir, sorry sir.
A chin tremor in adult, what do you think
Yes.
of?
Parkinson disease, sir.
Yeah, so basically chin tremors can be PD and hereditary spasms.
Yes, sir.
Hereditary spasm is one subtype, or the
Yes.
etiological cause, one etiological cause. So if you have
Yes.
head tremor, the patient comes in, sit in front of you, the head tremor, you think of ET, dystonic tremor, or primary, all those things. Isolated head tremors, all those things.
Yes.
Or cerebellar tremors. A patient comes to you with chin tremors, you think of these things. Patient comes in front of a jaw tremor, or
Again, sir,
body specific.
Parkinson. Then
Yeah, or body specific or part specific tremors are there. Jaw tremor, again,
yes.
Parkinsonism and dystonia, like ornamental
Yes.
dystonias.
Yes, sir.
And you were discussing about palatal. Okay, palatal.
Palatal tremor. So they are of two types: symptomatic palatal tremor. They arise from brainstem or cerebellar lesion, that is Gillian-Mollred triangle. So they are rhythmic contraction of levator velli palatine muscle, which persists during sleep. Then there is visible movement of the only at the edge of the palate, and it may be associated with cerebellar dysfunction, and MRI may show a hyperdense signal in the inferior olive due to inferior olive hypertrophy. Next. The second is essential palatal traumas. It is not associated with any CNS lesion. They are caused by rhythmic contraction of tensor velli palatini, and they are associated with ear click, and this ear click disappears during the sleep, and they are associated with movements of the of all the whole of the palate, while symptomatic tremors is associated with only movement of the edge of the palate. It is associated with the whole of the palate. MRI is typically normal in these patients, and they can be familial or functional in some cases. Next. Like in this video, we can see the palatal tremors. We can see the movement of the palate. Next. Coming to functional tremors, so they are previously known as psychogenic or hysterical tremors. They are very challenging to diagnose in neurological practice. They are of irregular frequency with sudden onset and sudden remissions. Frequency and amplitude are variable and they often diminish or disappear with destruction also. Co-activation signs may be present and they may be linked to some somatization disorders, and they may be influenced by external cue. Next. Like here we can see that the patient is having tremors. Like in right hand, initially in right hand he was also having tremor, but later only left side of tremors persist and right hand side diminishes. So maybe a functional etiology. Like here in this patient also we have tremors of the right hand. Like when she was asked to do some activity or during distraction, the frequency of the tremor changes. Next. So functional tremors, so the diagnosis and neuropsychological findings. So bad risk of potential are there. It is a measure of motor cortex activity detected during EEG back averaging. So it is absent in organic involuntary movements, and it is present. If it is present, it supports the functional etiology. However, the absence of this potential does not rule out the functional tremors. So the management is cognitive based therapy or physical therapy or removing the psychosocial issues of the patient. Next. Drug induced tremors. So there are various type of drugs which can produce the drug induced tremors, and they can be of enhanced physiological type or rest tremors or action tremors. So they depend upon the sign and symptoms depend upon the specific drug used and the patient's predisposition to side effects. Next. Drug induced tremors. Some drugs like antipsychotics can cause extrapyramidal side effects like bradykinesia rigidity tremors. So sometimes these tremors can be associated with extrapyramidal side effect. And management is tremor often improves with time and they may respond to dose adjustments. And but whenever tremors does not benefit from the dose adjustment or withdrawal of the drug, or worsening of tremor is there despite a stable medication dose, it should prompt an evaluation of new disease process in this patient. And persistent Parkinsonism more than 6 months after stopping the drug suggests the underlying Parkinson disease which was exacerbated by the drug. Now these are the list of drugs. The most common are bronchodilators, then anti-epileptics like carbamazepine, oxcarbamazepine, phenytoin. Then coming to the category are these theophylline, caffeine, and nicotine, mercury, lead, manganese, heavy metal poisoning, hypoglycemic agents, and many more. Next. Now coming to orthostatic tremors. So these tremors primarily affect the leg and can occur within seconds of standing, and they subside with the movement like walking, and also disappears when sitting or lying down position. They are having highest frequency 13 to 14 hertz detected by EMG, and they are often not visible to the naked eye, and it can be sometimes heard on auscultation and felt as vibratory sensation on palpation of leg muscle, that is calf muscle, also called as helicopter sign. Next. Orthostatic tremors, the treatment options are benzodiazepine, beta blockers, anticonvulsants like valproate, and then they can coexist in some movement disorder like essential tremors or Parkinsonism disorders. Next. Like here in this patient, when he was standing, we can see some movements. So these are the orthostatic tremors. Like EMG, we can see these movements. Next.
How will
Now
you
coming to
differentiate? How will you differentiate
yes.
orthostatic tremor from orthostatic myoclonus?
Orthostatic tremor from, sir?
Orthostatic myoclonus. Clinically.
Okay, I don't have any idea, sir. I didn't have heard the term orthoclonic myoclonus.
Orthostatic myoclonus is very common. Like you will see many patients with CKD, metabolic encephalopathy, when they walk, they will have this tremorlessness and they are unable to walk. They're actually most of them are orthostatic myoclonus. So orthostatic
Okay.
myoclonus, upon standing, they will have the myoclonus which is visually seen, and then they walk, it will worsen. While in orthostatic tremor, upon standing, patient doesn't have any tremors, and patient feel unstable and imbalanced. The patient presentation will be imbalanced on standing, and upon walking, orthostatic tremors improves. So on gait, they don't have any problem. They will have problem on standing. While in orthostatic
Yes, sir.
myoclonus, they have difficulty more in walking. If you see in those metabolic encephalopathies and CKD, particularly uremic encephalopathies, who are on dialysis, they come to you with ataxia, and they will have myoclonus. They will have orthostatic myoclonus that is causing it. Sometimes it is visually very visually seen also. On walking, you will see that jerkiness. It's
Yes,
very
sir.
common. It's not
Yes.
rare thing.
Yes.
But orthostatic tremor is rare, not common. So orthostatic
Okay.
tremor, they won't come with involved movement. They will come to you with imbalance on standing. That will be their symptoms.
Yes, sir.
On walking, they improve also.
Yes.
Now, tremor in Wilson disease. So, all type of tremors can occur in Wilson disease, and it should be considered in any movement disorder presenting before the age of 50 years. So, patient can have resting as well as postural tremors, which are more common, or can have classical wing beating tremor, which is not usually seen early in the disease, and it may be refractory to medications. Like here, we can see. We ask the patient to bring both the hands in front of the nose by abducting both the arms. So we can see the high amplitude of the tremors at the proximal joint as well as the wrist joint. Other associated neurological manifestation can be seen in Wilson disease are ataxia, Parkinsonism, dysarthria, dystonia, rhiscus sardonicus, associated systemic features and which may be associated with liver diseases or psychiatric manifestations like depression, anxiety, and psychosis. Next. Now coming to fragile X tremor syndrome. Fragile X tremor ataxia syndrome, which is a progressive late onset neurodegenerative disorder, which is associated with permutation of the CGG repeats in FMR1 gene. So this syndrome is being X-linked. It affects more males more than age of 50 years. Although female may be affected, but they are typically having milder symptoms. So the tremors are often the first symptoms in these patients, which occurs before ataxia by about 5 to 7 years, and in up to 20% of the fragile X tremor ataxia syndrome, the patient do not exhibit clinically observable tremors. Now coming to next back slide, please. So the patient can have cerebellar intention tremors, which is most common, or essential tremors also, or Parkinsonian tremors can be seen in this patient. Like differentiation from essential tremors, because in early stage these patients can be mistaken for essential tremors, but as the disease advances, patient can have cognitive issues as well as ataxia in these fragile X tremor ataxia syndrome. So, next. So the MRI findings is the patient is having hyperintensity of the bilateral middle cerebellar peduncle MCP sign, and we can have hyperintensity of the splenium of corpus callosum. And females usually show milder MRI abnormality. So here we can see the hyperintensity of bilateral middle cerebellar peduncle. Next.
Okay, Dr. Nidhi, can we summarize in next 5 minutes?
Sorry, sir.
Can we go fast?
Okay, okay. Yes, sir. Yes, sir.
Within 5 minutes.
Yes, sir. Yes, sir. Okay, sir. Last slide, please. Okay, okay. So the treatment, So the treatment, the patient responds to essential tremor medication, or we can go for DBS of ventral intermediate nucleus of thalamus. Next. So the spinocerebellar ataxia syndrome,
These are actually
type 12.
etiological. These are actually etiological causes of tremors. No, you will just see how will you approach tremor. How will you classify tremor?
Sir, I have covered the part in initial slides. Should I summarize?
Yeah, just summarize how will you, when the patient with tremor sit in an exam, how will you classify tremor and how will you approach it? Just that. Just summarize that.
Okay, okay. Last slide. Just last to last. So evaluation. Yes, yes. So evaluation of the patient with tremor. So we will observe what is the affected body region. What will be the abnormal?
So
Is there
initially,
any
how will
abnormal?
how will you, how will you classify tremors into?
So, sir, the tremors can be classified into rest tremors as well, and second is action tremors,
Okay,
and
then
action tremors are again classified into postural tremors, essential intention tremors, or dynamic tremors, task specific
no,
tremors.
no. Action tremors are classified into kinetic, postural, and isometric. Rest tremor, action tremor. So somebody comes to you and sitting in front of you, rest tremor, you think of the etiology is under rest tremor. Somebody has an action tremor, whether it is kinetic, postural, or isometric.
Yes,
So
kinetic.
kinetic is further divided into simple kinetic or pure kinetic, then intentional and task specific.
Yes.
Postural is further divided into pure postural and re-emergent.
Okay, sir.
So that is how you're going to approach. You have a rest tremor, you think of these causes: dopamine insufficiency or dopamine something which, it may be whatever etiology it may be stroke, it may be degeneration, it may be some genetic whatever, or it may be
Yes.
Wilson's whatever. But you will see the rest tremor, you think of it is dopamine blockade or dopamine insufficiency. It's a pure
Yes.
rest tremor. And
Yes.
if it is an action component with a kinetic, whether it is simple kinetic, intentional, or task specific. Then you see whether it's a postural, whether it is present during the initial part or after few seconds, maybe 12 seconds to 30 seconds later, you think of re-emergent tremor. Re-emergent tremor is very typical for
Parkinson disease.
IPD, predominantly IPD or Parkinson disease. And
Yes.
how will you evaluate kinetic tremor?
Kinetic tremors is our initial part में initial at the initial initiation of the movement it is initial tremors, mid of the movement is dynamic tremors, and then at the end of the movement it is essential tremors.
Classically, how De Jong tells simple
Sir,
kinetic and intentional, how to differentiate? These are practical things. Like simple kinetic is when you are during the pathway. If you have tremors on doing a finger nose, if you during the pathway you have tremors, that is a simple kinetic tremors during the action. Intentional is reaching the target, that is reaching the nose. It goes here and there is intentional tremors. That is a classical clinical teaching in Dijon.
yes.
Yeah. So
Okay, sir.
then postural you will examine for outstretched hands and other way.
Yes, sir.
So that is how you're going to approach tremors based on initial clinical thing. Then you can also approach based on the body specific, like head tremor, chin tremor, jaw tremor, palatal tremor, leg tremor. Leg tremor can be orthostatic tremor, orthostatic myoclonus, or somebody has a rest tremor in the leg. Think of IPD,
Yes, sir.
idiopathic Parkinson's. When somebody has a rest tremor in the leg, it is very, very, very likely that it will be IPD, idiopathic Parkinson's.
Sir.
Okay. Then you have all the head tremors, chin tremors, jaw tremors, palatal tremors, all those organ specific or body specific tremors.
Yes, sir.
Then how will you going to observe and see whether it is which body part and what is movement, whether it is rhythmic, arrhythmic, or jerky in nature, how what happens in action, what happens in all those things. Then what all things you will examine?
Like we will examine, sir, first during rest, then on position, then
Okay.
during movement, like finger
Okay.
nose movement, sir. Then we will look for other associated features.
Archimedes
Then we
spiral
can Archimedes type spiral. Yes, sir.
and
That
writing.
is
These two are very important. What about
the.
Archimedes spiral? What all things you want to see in Archimedes spiral?
So Archimedes spiral, we will look for the sir, like whether the
One thing.
patient is having uh, uh, tremors during whether the axis is present, like 10 to 2
Whether,
axis,
yeah,
so
yeah,
which
whether
indicates
the access is present. Yeah, when access is 2 to 8,
it indicates essential tremors.
more likely to be essential. What about dystonic tremor?
It doesn't have, sir, axis, and
And it is, you will see sudden jerky things
jerky
while
type
doing this.
things.
What
Yes.
about Parkinson's and ET?
In Parkinson, the patient will have more and more smaller circles,
Micrographia?
micrography.
Micrographia and essential tremor will be macrographic, and the circle with the Archimedes spiral will be much larger, and they will have the smooth tremors coming. May have an axis at 2 to 8.
Yes.
In essential
Then,
tremors, na, sir?
yeah, to essential tremors. Then
Yes.
what about drawing line? You can also do a vertical line drawing. Vertical line drawing, you can see the fine tremors coming and jerky tremors in the dystonic tremors. Then
Yes.
you
Fine.
look for the handwriting.
Yes, sir.
Handwriting, particularly if you write P, B, all those letters with long lines and
Yes.
circles, that will be more obvious.
Okay, sir.
And then you see for any other associated moments
Yes.
or any other associated neurological findings. That comes as secondary. That is not actually part of evaluation of, isolated tremors. It is comes associated things like associated Parkinsonian features, associated other movements. Then the etiology may be different. But the type of tremors, whichever you see, maybe in Wilson's, you will see other associated dystonias may be there, associated chorea may be there, associated Parkinsonism may be there. But the tremor, when you're explaining, you tell about whether it is rest, postural, action, or isometric tremor, and whether it is simple kinetic, whether it is intentional, like that you have to explain the tremors. Then you evaluate for the tremors.
Yes.
Noel sir, anything to add,
Yes.
sir?
No, I think everything is covered.
Oh,
The thing is, in that Archimedes spiral, I think that dystonia can have multidirectional axis,
Yes, sir.
while essential
yes.
will have unidirectional.
Yes, sir. Uh, so thank you, sir. Um, should I conclude my slides now, sir?
Yeah, one more thing is when you check for polyminy myoclonus, you have to keep the hand in, it should be in relaxed state. So you
Okay.
don't have to hold it in posture, it should be in relaxed state, and then you have to observe for the polyminy myoclonus.
Yes. Okay, sir. Salesh, sir.
I think Shailesh sir is not there, I think.
Yeah, next presentation
Yes.
we can start.
Okay, sir.
Dr. Dhanya.
Dhanya, you are not audible.
Oh, sorry, sir. Is it audible now?
Yes, it is audible now.
I'm sorry. Shall I start from the start?
Yeah, better to start from starting.
I'm sorry. Okay. We'll start. Good evening. Myoclonus. Myoclonus is a sudden, brief, shock-like involuntary movements. These are single or repetitive, jerky, arithmetic, asynergic involuntary contractions involving entire muscles or group of muscles. It can be positive myoclonus or negative myoclonus. Positive myoclonus is abrupt muscle contraction. Negative myoclonus is interruption of the muscle activity. So, negative myoclonus includes asterixis, epileptic negative myoclonus, bouncy like proximal negative myoclonus. So, Frederick was the one who first defined the myoclonus, essential myoclonus, separating it from the epileptic clonus and chorea. Initially, it was they also included tics and myokymia. Later, it was clarified by Lundborg by calling symptomatic myoclonus, essential myoclonus, and familial myoclonic epilepsy. Distinguishing from the other movements. Tics. Tics are brief, suppressible by will, often complex, preceded by the urge and followed by the relief, unlike myoclonus. Whereas chorea, it is a flowing, randomly distributed movements in the body and time. Individual choric movements can mimic myoclonus, but they occur within the continuous slow movement, which is in flow. Dystonic or myoclonic dystonia. These are brief spasms, may be repetitive, but drive body part into distinctive dystonic posture. Whereas in myoclonus, we may not see the abnormal posturing. These are slower or twisted postures. Tremors, these are rhythmic, but few myoclonus, such as cortical myoclonus in the fingers, may mimic the tremors. So, whereas in psychogenic jerks or functional jerks, these are inconsistent, reduces with distraction and trainment. And these also there is a variation in the muscle involvement, variation in the muscle recruitment order, variation in the burst duration or amplitude. And chorea also we already told, and there can in electrophysiologically there will be a variation in the burst duration and variation in the muscle recruitment. In motor tics, there will be a increase burst duration will be more than 100 milliseconds, and pre-movement potential or back averaging can be seen. In dystonic jerks, there will be a co-contraction of both agonist in electrophysiological agonist and antagonist, and burst duration will be greater than 100 milliseconds. There will be an overflow, unintentional muscle contraction that accompany the jerks, but is anatomically distinct from the primary dystonic movements. Whereas in tremor, there will be alternating contraction of antagonist muscles. There will be steady frequency on accelerometry. So classification of the myoclonus. We can classify the myoclonus multiple ways. Clinically, it can be spontaneous, action, reflex. Topographically, focal, axial, multifocal, generalized. In temporal pattern, it can be irregular, repetitive, rhythmical. And pathologically, this can be differentiated as cortical, subcortical, in subcortical, thalamic, brainstem, spinal, peripheral. Spinal again have segmental and propriospinal. In brainstem, we have again reticular, startal, and palatal. And in cortical, it can be focal, multifocal, generalized, epilepsia partialis continua. Etiological based, it can be physiological, essential, myoclonus of the epilepsy, and symptomatic because of the secondary causes such as storage disorder diseases, cerebellar degeneration, basal ganglia degeneration, dementia, viral encephalopathy, metabolic encephalopathy, toxic encephalopathy, hypoxia, and focal damage. So coming into the pathophysiology, a brief pathophysiology, sir, before going into the further. For cortical myoclonus, there will be an abnormal activity originating in the sensory motor cortex, transmitted by the via pyramidal pathways. So phenotypes in focal jerks, there may be a repetitive as epilepsia partialis continua, propagation to the focal motor seizures with or without secondary generalization. If it is a rapid rhythmic, it can be a cortical tremor. Brainstem myoclonus, we have multiple, like 3 different types: startle or hyperclepsy. It is exaggerated startle pathway. In brainstem reticular myoclonus, the generalized jerks independent of the startle will be seen. In palatal myoclonus, it is seen as a palatal tremor. And spinal myoclonus, it can be segmental or propriospinal. Segmental, it is restricted to the body part. Few spinal segments it is seen. Propriospinal, it is a generalized axial jerks, usually starting in the abdominal muscles. In peripheral myoclonus, lesions of the root or plexus or peripheral nerve can cause the myoclonus. And in peripheral myoclonus, most common thing we see is the hemifacial spasm of a neurovascular compression of the seventh cranial nerve, maybe viewed as the peripheral myoclonus. So, neurophysiological hallmarks for the localizing the these specifically according to the location. In the EMG polymyography, we can see burst duration from 10 to 50 milliseconds in epileptic or cortical. If it is spinal, it is 100 milliseconds, and greater than 100 in dystonic or functional. And agonist and antagonist synchronicity common in myoclonus. In cortical myoclonus, the things which we commonly see are giant SSEPs. They are enlarged P25 or N33, and N20 is often normal. And jerk log back averaging EEG, it's a cortical spike or wave preceding the EMG. C reflex, these are latency compatible with the fast corticospinal conduction. Abnormal corticomuscular coupling, increased cortical excitability. Whereas in brainstem reticular, there is no cortical correlate, which we see is in the cortical myoclonus, and SEPs will be normal. Activation sequence starts in the lower brainstem, that ascends and or descends. In propriospinal, onset is in rectus abdominis with rostrocaudal spread. In functional myoclonus, it can be variable or prolonged latencies. Brainshaft's potentials precedes the jerk. Distractibility or placebo response, complex jerks, incongruent to the neuroscience. So, while going
What
into
is
the
that
history,
Beretschaf potential?
sir, in functional myoclonus, when they want to project, have the movement, first initial we'll see a spike in the cortical recording before the movement have started.
Okay, correct. So how will you do that? So basically you have to have EEG recording also and surface EMG
And
recording.
surface EMG. Yes, sir.
So this EEG recording, if you're checking in the upper limbs, then usually it is in centroparietal region, those electrodes are used.
Okay, sir.
And for lower limbs, the central electrode CZ, PZ can be used. So it is like a premotor potential, which is
Yes.
a cortical potential, which comes around 1.5 to 2 seconds before the voluntary movements.
Well, yes.
So if it is before the voluntary movement occurs, that is, if it precedes the jerk, that means it is likely to be a voluntary movement. That is seen in functional myoclonus.
Yes.
That won't be seen in cortical
No,
myoclonus.
cortical myoclonus.
It is also absent usually in tics, or it can be, or the duration can be very short, or it can be absent in tics. That's how you can differentiate it from functional.
Okay, sir.
Secondly, this jerk locked back averaging EEG is also similar. So you see whether the myoclonic jerk which is coming, whether it is correlating or it is locked with the EEG jerk or the jerk which you get in EEG also. So the EMG jerk and the EEG jerk should be locked, or it should be similar, that is jerk locked. But that will be seen in cortical myoclonus only. In brainstem reticular, propriospinal or peripheral, you may not get.
Yes, sir.
Because it is not generated from the cortex.
Yes.
Okay.
Okay. So first, while going into the history, age of onset, which helps us to mainly guides us into the. Sir, I'll discuss this little further. I'm just initially giving. So it guides major etiological category. Infancy or childhood onset with seizures, ataxia, and cognitive decline will let us know into the leads to epileptic myoclonus. So mode of onset is also important, whether it's an acute or subacute or chronic. If it's acute or subacute, the acute causes like metabolic causes, hepatic or renal failure. Usually we see a negative myoclonus here. Electrolyte derangements and thyrotoxicosis, neuroinfections such as HSV, arbovirus line, post-hypoxic and vascular events, stroke or hemorrhage, post-traumatic, drug or toxin-induced, autoimmune or inflammatory or paraneoplastic. If it's chronic progressive cause, if it's chronic and progressive neurodegenerative, we should think of neurodegenerative diseases or PME syndromes, genetic epilepsy syndrome. If the progression also helps us whether it's a static versus progressive. Course helps to stratify if it's a structural or metabolic versus degenerative. In degenerative, it is progressive. Precipitating and relieving factors should be asked whether it's triggered by action or startle or any specific medications. Any associated symptoms like seizures, cognitive decline, ataxia, dystonia, Parkinsonism, and other movement disorders. So we have to ask about the medication history. Any recent introduction of any antipsychotics, antidepressants, opioids, antibiotics, etc., may also precipitate the myoclonus. And comorbid systemic conditions like hepatic, renal, endocrine, infections, autoimmune, or any neoplastic backgrounds should also be checked. Family history will definitely help us to narrow the genetical differentials. So if there is a immediate family member who is affected, we can think of the autosomal dominant. If there is a there is not no immediate family member, the next before generation is affected, we have to think about this metabolic disorders such as Gaucher's disease, Wilson's, GM1, NBIAs, and PME syndromes. In autosomal dominant, myoclonus dystonia, SCA, Huntington disease, DRPLA, familial cortical tremor, and if it is a mitochondrial inheritance, MRF, we have to think of. And physical examination focuses areas, body distribution should be checked, whether it's a focal, segmental, multifocal, axial, generalized. And activation patterns, whether it's is it spontaneous or action induced. If it's action induced, voluntary movement, how it is. And stimulus sensitive, whether it's a touch sensitive, sound sensitive, or visual stimuli, if any sensitivity. Temporal, continuous or versus intermittent, rhythmic versus irregular. Associated neurological signs like ataxia, as we already told. And physiological myoclonus, we have physiological myoclonus which are benign, which includes hypnic jerks. And essential myoclonus is often familial, isolated, without any other neurological deficits. Epileptic myoclonus occurs within an epilepsy syndrome, common in the childhood onset, with seizures and cognitive decline. And symptomatic secondary myoclonus is due to the structural, metabolic, toxic infections, autoimmune, degenerative, or paraneoplastic causes. So this is a phenotypic base. So myoclonus, once we know the body distribution, is it focal, multifocal, generalized? So once we know this, is it a stimulus sensitive? If yes, definitely it is. It mostly go into the cortical myoclonus or cortical subcortical myoclonus. If it is not stimulus sensitive, then we should think it as peripheral myoclonus or spinal segmental myoclonus. If it is multifocal, stimulus sensitive, again it is cortical myoclonus or cortical subcortical myoclonus. If it's not, then it is essential myoclonus. And in a generalized myoclonus condition, whether the facial muscle is involved or not. If they're not involved, it's propriospinal myoclonus, occurs at rest, stimulus sensitive to tapping abdomen on tendon reflexes, and tendon reflexes we can see. And if it is facial muscles are also involved, whether it's a spontaneous or action induced. If it's spontaneous, we have to think of brainstem reticular reflex myoclonus. And if it's action sensitive, then it's hyperklepsia, or only stimulus sensitive to this. In this, it's mainly auditory and tactile stimuli. So going into the focal, I'll just expand a little further, going into little more etiologies. focal or segmental myoclonus. This focal or segmental can be, as we already saw, it can be peripheral, spinal, brainstem, and cortical generator. The clue can be it is usually rhythmic, segment confined, persists even in the sleep. Then it is a spinal segmental. If it is stimulus sensitive, distal jerks are seen, it's cortical. More than brainstem also we can see stimulus sensitive, cortical is more common. And other one is ear clicking or palate. It's called palatal tremor, or as already in previous discussion we have discussed essential and symptomatic palatal myoclonus. And spinal segmental myoclonus, it is usually 0.5 to 3 hits. It's segment limited, even persists in the sleep, often due to the loss of posterior horn inhibition. And
It is because of few contiguous segments of spinal cord. Those
yes.
are.
So the causes for the spinal segmental is usually inflammation, infection, demyelination, tumor, AV malformation, ischemic myelopathy, and spondylitic myelopathy, spinal anesthesia, and idiopathy. So palatal myoclonus, I think I'll skip this before we just discussed. I'll just tell the two important points. In essential palatal myoclonus, tensa villi palatini is the more common seen, and there will not be any inferior olivary hypertrophy. It's because of the in symptomatic palatal myoclonus, it's mainly involvement of the Guillain-Barré triangle, and inferior olivary hypertrophy is seen. And in focal cortical myoclonus or essential myoclonus, this EEG or EMG will be jerk locked. It's cortical spike, as sir already told, and both the EEG and EMG have the same time spike, and SSEPs will be very high, giant, and EPC will show continuous focal jerks hours to years. This is epilepsia partialis continua. Causes include Rasmussen's encephalitis, cerebrovascular lesions. Treatment usually seizure directed. In Rasmussen, immunotherapy can be tried, and selected low frequency TMS can be given. And peripheral myoclonus, often after the peripheral nerve or the root or peripheral injury, hemifacial spasm is one of the example, and treatment can be given botulism toxin for the hemifacial spasm. For axial, next going into the before we just discussed focal, axial. Axial can be neck or trunk flexion, arm abduction, or hip flexion. Generators are from spinal or brainstem. If propriospinal myoclonus, it's a truncal flexion jerks, often verse supine or sleep wave transition, premonitory sensation, high psychogenic prevalence in the series. We have to look for the till now. So many, most of the cases propriospinal which were described were of psychogenic, and we have to look for the Brenshaft potentials. Treatment is clonazepam, or if any spinal structure, a few cases have reported with the spinal structural injury. So if any spinal structural problem is there, we have to treat that.
Usually,
Next.
where is the lesion? Usually the lesion is in cervical or thoracic spinal cord. Usually two or more spinal segments are usually involved.
Yes.
Okay, so that's why they can have multifocal kind of involvement also.
Yes.
So what about the electrophysiology in these patients?
So
the SSEP will be normal.
Normal.
Because there is no cortical involvement.
Yes.
And then that EEG, that time lock pattern is also not seen.
Not, yes, sir. Shall I go to next? Next, brainstem reticular or exaggerated startle. This myoclonus originates in the caudal brainstem, and muscles are activated by the brainstem and down the spinal cord. So the myoclonus is generated and mainly axial to cause the neck flexion, shoulder elevation, and trunk and knee extension. Reticular reflex myoclonus. This is a spontaneous jerks, common, limb predominant stimulus sensitivity. It is fast. It has fast conducting bulbospinal pathways. Whereas in exaggerated startle, they have slow conducting bulbospinal pathways. Falls are common. It is evoked by sudden auditory, visual, somatosensory stimuli. And in hereditary hypertepsia, GLAR1 and or others, infant stiffness phenotype possible. And treatment is usually with clonazepam and with or without valproate or pyracetam. Manage precipitants and symptomatic forms.
So
And
what
other
is
one
the
is,
difference between this hyperexplexia and startle, normal physiological startle?
so hyperclepsia is exaggerated startle reflex, sir.
Oh, yeah, exaggerated symptomatic, and it is non-fatigable. So
Non-fatigable.
the number
Yes.
of stimulus, if you keep on giving the stimulus continuously, the startle will keep on coming. While in physiological startle, the response decreases, that it is fatigable.
Yes, sir. Mm,
What is the duration of this brainstem reticular?
yes, sir. Usually, its burst duration will be greater than 100 milliseconds.
Yes,
Sir.
it is greater than 100
Uh,
because usually what we see is, as you said, ki there is the spread of excitation
Yes,
from
sir.
caudal to cranial.
Yes, sir.
So as the spread of discharges occurs, so according to that, there is myoclonus seen. So though the myoclonus can appear generalized, it is because of the excitation of multiple muscles. So
Yes.
that's why the duration can be more than 100 milliseconds.
Yes. So basically, this brainstem reticular reflex myoclonus is origin from the lower medullary reticular formation, sir. I'll just go back. So orthostatic myoclonus. So the leg myoclonus on standing, unsteadiness. Sorry, I have to change this. So unsteadiness, as already we discussed in the previous session, they will not be able to walk. They'll have difficulty in walking. They have buckling of the knees while they're walking, and they will fall because of the orthostatic migraines. And the other one is multifocal and generalized cortical myoclonus. The multifocal is bilateral asynchronous jerks, usually mini polymyoclonus in fingers or toes, often stimulus sensitive. EEG cortical correlates and giant SSEPs are common. They are generalized, maybe cortically generalized or brainstem reticular mechanism can also coexist in the multifocal. So for the cortical myoclonus, the clinical features usually will be distal. So this is from here. It's kind of summarizing the cortical, subcortical also. Each slide, I'll just summarize it. For the cortical, it's mainly distal upper limbs and the face due to the large cortical representation. It's action-induced, stimulus-sensitive, tactile more commonly, visual, auditory. It can be focal, multifocal, generalized via cortical spread. Neurophysiologically, EMG shows a brief 25 to 100 milliseconds in duration and spread to the antagonist and other contiguous muscles. Burst will be less than 50. EEG, EMG back averaging will be seen. And for the arms, it is 20 milliseconds, and for legs, it is 30 milliseconds. SSEP will be giant in P27 and N35. C reflex will be exaggerated. Sir, I didn't understand what is the C reflex. What is this
So
one?
it is like H. You know what is H reflex?
Yes, sir.
So H
Lower
reflex
limb
is like
system.
yeah, it is a electrophysiological correlate of ankle reflex.
Yes,
But
sir.
but like ankle reflex, it is a spinally mediated reflex.
Okay, sir.
But this C reflex is the reflex which has cortical involvement also. So like the afferent will go to the cortex and then it will come through the efferent nerve and it will be detected. So that is called as C reflex. So basically it is H reflex. It is similar to H reflex, but H reflex is spinally mediated and C reflex is cortically mediated.
Cortical immediate. Okay,
So
sir.
that's why in cortical myoclonus, it will be exaggerated. But
Okay.
in subcortical, all
It's will be
subcortical
normal.
myoclonuses, including segmental and peripheral, it will be absent or normal.
Okay, sir. Okay. So mechanism is cortical hyperexcitability, GABAergic dysfunction, abnormal corticothalamic cortical loops. And so the etiologies which we see in the cortical is PME or other epileptic syndrome like Lafora body disease, Unwachit Lundberg disease, neuronal ceroid lipofuscinosis, amyloidosis, myoclonic epilepsy with red ragged fibers in mitochondria, and epilepsy partially continuous seen in Rasmussen encephalitis, familial cortical myoclonic tremors with epilepsy. In neurodegenerative conditions such as Alzheimer's, CJD, corticobasal syndrome, dementia with Lewy body, and MSA, Huntington disease, Westphal, especially Westphal variant, spinocerebellar ataxia like 2, 3, 14, 19, and progressive myoclonic ataxia syndromes. Infections such as SSPE, HSC, herpes simplex, Whipple's disease, and post-infectious encephalitis. In metabolic causes, we can see in hepatic failure, renal failure, dialysis disequilibrium, Hashimoto's encephalopathy, hypoglycemia, non-ketotic hyperglycemia, hyponatremia, and celiac disease-related neurological manifestations. And drugs or toxins such as lithium tricyclic antidepressants and methyl bromide, and focal CNS damage like post-stroke, post-traumatic, or neoplasm. And one more thing I've seen is an idiopathic progressive syndrome with cortical action myoclonus as the main symptoms has been described in older individuals with primary progressive myoclonus of aging. And sir, shall I discuss these or we'll go to the next, sir? These are like epilepsy descriptions.
You go to next slide.
Only one video. This is the patient showing having the myoclonus. This is SSPE patient, sir.
Okay, so in SSP, there is something called a slow myoclonus.
Slow myoclonus.
It is generalized, but usually involves more of axial muscles than the other muscles. And
Yes.
the duration can be more than 100 milliseconds. So that's why it is called slow myoclonus.
Yes.
It is a cortical, subcortical kind of myoclonus.
Oh, yes. So before and negative myoclonus is also like a sudden interruption of the tonic muscle activity and drops, lapses, buckling, sometimes leading to the falls, very disabling in the proximal limb involvement. In epileptic negative myoclonus, time lock to the EEG epileptic discharges is seen. In subcortical negative myoclonus, it is seen in as astraxis, seen in hepatic or renal failure or metabolic encephalopathy. Mixed negative myoclonus is seen in post-hypoxic states. In cortical subcortical, there will be an abnormal oscillatory between the cortical thalamic circuits seen in generalized epilepsy syndromes. And they may have, if it further spread, they may have the loss of awareness. Generalized jerks, often bilateral and synchronous, may coexist with the absent seizures or GTCS. EEG may show generalized spike or polyspike wave discharges that correlate with the myoclonus because it's both cortical and subcortical. EMG bursts also, duration will be 25 to 100 milliseconds. In subcortical or non-segmental, as already we discussed, we have four. It includes brainstem reticular reflex myoclonus, startle or hyperclepsia, propriospinal, and multifocal jerks in the myoclonus dystonia. And the EMG burst will be 25 to 300 bursts. And the origin will be from the cortex and the spinal cord. It will be spreading rostrocaudal EMG recruitment. And there will be no EEG correlates, no cortical spikes, or no giant SSCPs. So in brainstem reticular reflex, as we already told,
We have discussed this. You can go ahead.
Yes, sir. Yes, this also we have discussed, sir. Just causes I'll tell, sir. Startle reflex, the pathological exaggeration of the normal startle reflex is in hereditary hyperclepsia, idiopathic hyperplexia, and symptomatic startle syndromes, and static encephalopathies like perinatal encephalopathy with tonic spasm, post-anoxic encephalopathy, traumatic encephalopathy. In brainstem encephalitis such as sarcoidosis, viral encephalomyelitis with rigidity, multiple sclerosis, and paraneoplastic. And this propriospinal also we have discussed, sir, mainly from the abdominal tapping or triggered by abdominal tapping or tendon reflexes. And burst duration is 100 to 5000 milliseconds as it's not going to the cortex. And segmental myoclonus, restricted segment to the brainstem or spinal cord. This can be rhythmic or semi-rhythmic, persists during the sleep, and not modified by the voluntary control, stimulus independent. This also have EMG of 50 to 1000 millisecond bursts. This includes palatal and spinal segmental. This also we have already discussed, essential and symptomatic palatal tremor. Mainly in symptomatic, it is persists in the sleep, and lesion is in the Guillain-Molleret triangle. And peripheral myoclonus, mainly hemifacial spasm, any damage to the nerve or plexus or root pathology. It's mainly ectopic excitation, and the duration of these discharges may range from 50 milliseconds to 200 milliseconds or longer. And post-hypoxic, it can be an acute or Lanz-Adams. In acute, it is myoclonic status post-cardiac arrest. And Lanz-Adams is a action or stimulus-sensitive myoclonus with ataxia. It's a serotonergic mechanism is suspected. In infections or autoimmune myoclonus, which we see are SSPE, these are periodic long interval myoclonus, periodic EEG is seen. In CJD also we'll see this. In OMS, paraneoplastic or para-infectious, and ACTH or rituximab or cyclophosphamide is there. And degenerative causes Alzheimer's and CJD, and MSA or PD we can see orthostatic myoclonus, and dystonic myoclonus can be seen, and and corticobasal disease degeneration, stimulus sensitive myoclonus is more common. In drugs, already we have told, like SSRIs, opioids, anesthetics, and any withdrawal of benzodiazepine or propranolol, and serotonin syndrome. Serotonin syndrome can have, sir, in serotonin syndrome only, no, sir, they have ocular clonus or myoclonus, sir.
They can have ocular
Yes. And gabapentin can have positive or negative myoclonus. In essential myoclonus or myoclonus dystonia, non-progressive multifocal myoclonus with or without dystonia, and functional sarcoglycan associated, this one is most commonly seen as essential myoclonus and genetical cause. And psychogenic
SCGA mutation they present with myoclonus dystonia. It is usually seen in young patients, and they present with writer's cramp or writing dystonia, and on examination they have slight jerking component also.
Okay, sir. And functional or psychogenic myoclonus frequent in axial or propiospinal muscles in like presentation, conform with the neurophysiology. And other one we have to know, other myoclonus we have to know is opsoclonus myoclonus syndrome, dancing eyes, dancing feet syndrome. Opsoclonus is continuous, arrhythmic, multidirectional, large saccades. Myoclonus is trunk, limbs, diaphragm, larynx, pharynx, and palate of the myoclonus. And the causes most commonly seen are viral infections, post-infectious encephalitis, trauma, tumor, toxic, and drugs. 50% of the children with neuroblastoma, which is present in chest or abdomen, can be seen. Only 2% of those with the neuroblastoma of opsoclonus myoclonus, and 20% of the adults having the underlying cancer can also have. And other causes which we see, the subacute onset of the ataxia, dysarthria, diplopia, and ophthalmoplegia, nystagmus, opsoclonus, vertigo, deafness in myoclonus in the brainstem encephalitis. Causes are viral infections such as herpes, bacterial infections such as listeria, post-infectious causes, demyelination, vascular disease, and in paraneoplastic causes, so anti-Yo and anti-Re antibodies are seen. Most common cancers associated are ovary and lung. And epileptic myoclonus we already discussed, sir.
Yes.
And etiological also, I think we have already covered almost
we have covered
everything.
all this. Yes.
Yes. So drugs also we have just covered, sir, all the drugs which are causing the myoclonus. So this is also just a
This
final
also we have discussed. Yeah.
discuss. So investigations, we already told, in neurophysiology we have to see EMG, EEG, and C reflex and SSEPs, and imaging should be done for look for the inferior olivary, for the palatal, and etiological labs to confirm the metabolic infections, autoimmune or genetic causes with or without. And management will be like, if any precipitants are there, to remove the I'll just go further, sir. For the subacute causes, we have to look for the laboratory for the metabolic conditions, and other I think this also we have discussed, sir, infections, which infections are causing mainly, like HSV, herpes zoster, Epstein-Barr virus, HIV, malaria, syphilis, cryptococcus, and
Yes,
gonorrhea,
we discussed.
and CJD we've discussed. So once we know the anatomical substrate, once we have done with the electrophysiological testing, we'll know whether it's a cortical or subcortical, spinal or peripheral. And for spinal peripheral, we'll be doing the spinal cord imaging. And for the cortical, if it is like a medication or toxic agents are there, then we have to remove them, or no. Then we'll go for the routine laboratory testing and brain MRI, and no cause is identified. Then we have to, if it's a chronic progressive condition, then we have to think of a mitochondrial or late onset any neurodegenerative disease. And according to it, we'll go for the target sequencing. And we shouldn't miss the inborn error metabolism, where the treatment can improve the condition, like tyrosine hydroxylase deficiency, CTX, where we can give quinodeoxycholic acid, and Niemann-Pick disease, miglustat, and GLUT1 deficiency, we can start them on the ketogenic diet, and metal storage disorders like Wilson's. So these also should be evaluated. So these are like two things to just see, sir. If it is a childhood onset or adult onset, having cognitive decline plus seizures plus myoclonic gest, then we have to think of the PME. If elderly patients with myoclonus and dementia suggestive and rapidly progressive, it is suggestive of CJD, and slowly progressive, relatively not rapid compared to CJD, it's corticobasal syndrome, DLB, AD. And acute onset myoclonic jerks with encephalopathy is seen in metabolic disorders, drugs, neuroinfections, paraneoplastic hypoxic brain injury. And if they have the chronic myoclonus with ataxia, we have to consider SCAR2-3, DRPLA, Friedreich's ataxia, and ataxia telangiectasia. And it is very important to search whether the myoclonus appears at rest or on posture. On posture, negative myoclonus should be seen. Then the renal hepatic failure should be checked, or action induced, it's cortical. Auditory stimuli, brainstem, or tactile stimuli is also cortical. And focal or multifocal myoclonus can be of cortical or spinal origin, but unlike spinal myoclonus, cortical myoclonus disappears in sleep. And generalized myoclonus is usually of brainstem or propriospinal origin. So this is the treatment, sir. I'll just read these. These are the drug of choice. For the cortical myoclonus, it's valproic acid or clonazepam. And other agents, second agents we can give was primidone, phenobarbital, levetiracetam. For brainstem reticular myoclonus, valproic acid or clonazepam. Hyperclepsia, it is clonazepam. And carbamazepine and
Basically,
phenytoin.
cortical, you can give valproate,
Valproate
clonazepam,
acid.
or levetiracetam.
Okay,
For subcortical or non-segmental myoclonus, clonazepam, you can give zonisamide also.
Okay, sir.
And then for segmental, you have clonazepam, and you can give Botox also.
Botox.
Botulinum
Okay,
toxin.
yes, sir.
Same for peripheral myoclonus.
Same
You
as
can give botulinum
clonazepam.
toxin, clonazepam, or carbamazepam also.
So I'll just go into the next topic, sir, tics. Or we'll
Yeah,
discuss
in 10 minutes you
myoclonus.
can finish.
Okay, sir.
In next 10 minutes you can finish.
Yes, I have
rapidly.
just 10 slides for this, sir, not much. So tics are defined as sudden, rapid, recurrent, non-rhythmic motor movements, or motor tics, or vocalizations, vocal or phonetic tics. And I think there are some sensory tics also. Individuals with tics often experience an unpleasant sensation preceding the tics, referred to as premonitory urge, which is temporarily relieved by execution of the tics. Unlike other movement disorders, tics can be voluntarily suppressible for various variable periods, which is known as tic suppressibility. And tics are divided into either primary or secondary tic disorder. In primary are the more common. Secondary are very rare and can be caused by acquired or genetic disorders, chromosomal or heterodegenerative. And most commonly, they are pediatric onset. If they are adult onset primary tic disorder is rare, usually associated with either underlying neuropsychiatric disorders, and it is also seen with Huntington disease and neuroacanthocytosis, along with the chorea and tics and other movement disorders. Head or peripheral trauma, basal ganglion stroke, HIV infection, neuroleptic and anti-epileptic side effects, or cocaine abuse. Indeed, many adult tics are reoccurrences or continuation of the childhood tics. If the patient has an isolated tic disorder, it's further testing is not necessary. So the pathophysiology described was impaired function of the corticostriatal thalamic cortical circuits with aberrant association with neurotransmitter function, including dopamine, serotonin, and GABA, and development related atypical functional brain connectivity. And there are also few genetic, I have not mentioned here, sir. There are also few genetic contributions, strong high hereditary was seen in few genetic diseases. And both motor and vocal tricks are classified as simple and motor tricks, simple and complex. Sorry, simple motor tricks are brief, abrupt, repetitive, and seemingly non-purposeful movement, involve only one muscle group or any body part like face, neck, shoulder, or hands. Motor tics most frequently involve the eyes and mouth, followed by the neck and the limbs. Feet and midline axial structures are the least frequently involved. The essential clinical feature of tic disorder, such as early onset, waxing, the essential features are waxing and waning course. They may have echolalia. Echolalia is repeating others' words. Coprolalia is using offensive words. Echopraxia is repeating others' actions. So these simple motor tics can be subdivided into clonic, dystonic, and tonic tics. Clonic tics are abrupt, rapid, brief jerking movements like blinking, facial grimacing, head jerking. And other examples are eye rolling, wide opening of the eyes or mouth, tilting the neck, raising the shoulders, shaking the hands. And dystonic tics are kind of slower, resulting in the brief, sustained abnormal posture, a prolonged involuntary upward deviation of the eyes, eye closure, bruxism, mouth opening, or torticollis. In tonic tics are isometric contraction, tensing of the abdominal and limb muscles. And some tics may result in the transient interruption of the ongoing motor activities of speech without loss of consciousness. Such tics are often referred to as, these are known as blocking tics. And whereas the complex motor tics are caused by several muscle groups, and sometimes appear to be purposeful, coordinated, or orchestrated patterns of movement. And for these examples are touching, tapping, waving, kicking, jumping, echopraxia, and copropraxia. And simple vocal tics are meaningless sounds, maybe like moving air through the nose, mouth, and throat. And vocal tics are often referred to as phonic tics because of the sound may be produced not only by the contraction of the vocal cords, but also by the contraction of the nasal, oral, laryngeal, and pharyngeal and respiratory muscles. For this, examples are coughing, throat clearing, grunting, mimicking animal noises, and tongue clicking. So complex vocal tics are because they use several muscle groups, like they use words, phrases, sentences. Examples are shouting, grunting, yelling, echolalia, and coprolalia is also complex vocal tics. And if the provisional tic disorder is in less than 1 year duration, persistent is chronic motor or vocal tic disorder. Tourette disorder is also known as Tourette syndrome. The other specified tic disorders and unspecified tic disorders are also there. The first three tic disorder required that the onset should be before the age of 18 years, and the symptoms not be caused by other medical illnesses such as Huntington, substance abuse, or medical side effects. So this provisional tic disorder is considered when the tics have been present for less than a year since the tic onset. If in persistent tics, chronic motor or vocal tics, disorder is diagnosed when the individuals have exhibited either motor or vocal, but not both at the same time during the illness. Whereas in Tourette syndrome, both motor and vocal tics have occurred during the course of the disease, though not necessarily concurrently. Tourette syndrome can be diagnosed. This tend to have a higher severity of tics, greater prevalence of complex motor tics, and more comorbid symptoms than the patient with the persistent motor disorder. And than like the few motor tics maybe looks like a stereotypy. This stereotypic is not used for this because that gives a different meaning. And stereotypy are like there are more rhythmic or repetitive. They may not have the urge, so this is not used anymore. Tics usually follow a waxing waning pattern in severity and frequency with a mixture of old and new tics. So maybe temporarily exaggerated by the psychological strains like stress, anxiety, excitement, anger, and physical strains, fatigue, sleep deprivation, and infection and environmental changes. Most patients with tic experience significant improvement or complete resolution by the adult onset. And the most common causes associatedly seen were decrease in the Apgar score at the 5 minutes of the birth, and late beginning of the prenatal care of the mother, low birth weight, and prenatal maternal smoking, environmental factors, and genetic causes, as I already told. It was described in the CNTNAP2 gene on chromosome 7. In the family who have the tic disorders, it was seen, and NLGNG4 gene was also associated, and they may have associated neuropsychiatric disorders such as autism spectrum, ADHD, learning disorder, anxiety, and depression. And Tourette syndrome also have the comorbid features of other psychiatric conditions: ADHD, OCD, autism spectrum, depression, anxiety, sleep disorders, migraine, and self-injurious behavior. This is one of the patient I have seen. This is a home video. At hospital, he was not doing. At home, he'll be sitting and shouting like this. He's in fact an MBBS doctor who is working. This patient, actually, it was a lab, so I have to hold him. Apparently, at home, he will bend like that and he will start crawling all over the home and then get back and start shouting. So other entity we have to know was pediatric autoimmune neuropsychiatric disorder associated with streptococcal infection. It's called PANDAS, a subset of children with acute onset of tics or OCD following a streptococcal infection. The diagnostic criteria include presence of either OCD or tic disorder or both, onset before the puberty between the 3 and 12 years of age, abrupt, dramatic, and explosive onset or episodic course, a relapsing and remitting clinical course of symptoms with temporal relation associated with streptococcal infection, and other neurological symptoms such as hyperactivity, anxiety, coriform movements, or tic during the exacerbation. So management will be mainly educate the family, teachers, classmates, and characterize motor or phonetic tics, stereotyping, compulsive blocking, premonitory urges, and explore other behavioral comorbidities, and explain them about the neurobiological, neurophysiological, and genetic basis, discuss about the vaccine waning course, and discuss treatment options and strategies. If the symptoms are troublesome, then prioritize and customize, treat the tics before the ADHD. For the tics, behavioral treatment, CBIT is the best treatment. A pharmacotherapy we can give was alpha 2A agonist, dopamine depleters or blockers, topiramate, Botox, and DBS in medically refractory cases. And comorbidities, if they have, we can try on CNS stimulants, SSRIs, and SNRI. And other there are few experimental therapies which are tried. And DBS was tried for the thalamus, globus pallidus internus, globus pallidus externa, and anterior limb of internal capsule and nucleus accumbens. And various movements can resemble this. That's it. Thank you.
Okay, so important in tics is that they have premonitory urge,
Yes,
and after that
suppressibility.
tic is done, they feel better also.
Yes.
And there is suppressibility. So because tics can have multiple or different phenomenology, this is important to differentiate it from other movement disorders.
Yes, sir.
Okay, anybody have any question? They can ask. What is difference between fixed and stereotypy?
Sir, stereotypy is an like kind of habitual, sir. It is usually more rhythmic or repetitive, and they will not have the urge, sir.
So stereotypy are usually they are repetitive and they are similar kind of movement which is fixed. So tics can have different kind of phenomenology sometimes, and it is more brief as compared to stereotypy.
Stereotypy, yes.
Plus, stereotypy usually does not have premonitory urge and suppressibility.
Yeah, then we can conclude the session. Thank you, Dr. Noel and Dr. Baishak for moderating this session. And thank you, Dr. Nidhi and Dhamma for presenting through this session. And thank you, everyone, for attending. We'll conclude. Thank you, everyone.
Okay, thank you.
Thank you, sir.
Thank you.